Hello, and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts who present this weekly series on behalf of the Canadian Premature Babies Foundation. I'm a career broadcast journalist and mom to 3 NICU grads, including preemie twins who were born at 32 weeks and are just about to turn 13. I live and work in Mi'kma'ki outside of Moncton, New Brunswick. Well, Preemie Chats is the creation of the Canadian Premature Babies Foundation. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. I hope that you will take some time to visit our website. You can see it there on your screen, canadianpreemies.org. On the website, you will find resources, you'll find links to our previous Preemie Chats, a replay of this discussion when we're finished today. You'll find our podcast, our parent handbook for respiratory illnesses. Most importantly, what you will find at canadianpreemies.org is a community of parents and professionals who are working together to help our children thrive. I would love to know where you're watching from and where you're joining from today. Please, as we go through our presentation, feel free to leave your questions and your experiences in the comments. I'd love right now if you'd let us know where you're watching from and what brings you to Preemie Chats today, whether you are a parent, a grown preemie, a healthcare provider. We would love to know who is joining us and where in the world you are watching from. Today, we're going to take a look at the past, present, and future of Surfactant, a life-saving foamy substance that helps preemie lungs stay open and operating. We're going to learn a little bit about the history and discovery, how it's been used to help preemies, and the new ways in which it's being delivered today. And to take us through that journey, we're going to be joined by Dr. Georg Schmölzer. He's director of the Center for the Studies of Asphyxia and Resuscitation at the University of Alberta. He's also a professor of pediatrics, adjunct professor of physiology, and adjunct professor of pharmacology at the University of Alberta. He's a clinician scientist and practicing neonatologist with the Northern Alberta Neonatal Program. Welcome to Preemie Chats. Hello.
Hello. Thank you, Jenna. And thank you for having me today at the Preemie Chat to talk about Surfactant, one of our greatest therapies we have available for our preterm babies straight after birth.
Wonderful. I'm really looking forward to the information you're going to share. So we're going to bring your presentation on and turn it over to you.
Thank you so much. It's my great pleasure to talk to you a little bit about the story of Surfactant. And as with many things in neonatology, is that a lot of the treatments we do nowadays are kind of handed down from the adult medicine, where there were discoveries in adults, and then based on the things they discovered, things are often then miniaturized or doses are reduced to treat our premature babies. Surfactant is one of those few things which is much more prominent in neonatology, and is one of those stories which comes out of neonatology and is used in pediatrics as well as in adult medicine as well. But the main indication, the main focus of this treatment is in neonatology. It's one of these few things which came out of neonatology and has spread to a certain degree into the adult world as well. Now, why do we need Surfactant? And this is one of the first questions we should explore a little bit, because Surfactant is something which is extremely vital. Well, we need it because, in particular, babies who were born premature have challenges from a breathing perspective. Within Canada, within around the world, roughly 1 in 10 babies are born premature, which means they are born less than 37 weeks gestation. And if you're born between 37 to 42 weeks gestation, you are generally regarded as a term infant. So in Canada, around 330,000 babies are born. So if you think 1 in 10, it's around 30 to 35,000 babies who are born premature and potentially lack surfactant, which is life-saving for any of us here. Why is surfactant so important? Well, I will go in a few more details in the next slides as well. But everybody who is alive, any human, any mammal, will have surfactant in their lungs. And surfactant actually helps you to keep the lung open so that you don't, so that you can actually breathe. And we'll talk about this a little bit more. When you're born premature, there is two conditions which are problematic and result because premature babies often don't have enough surfactant. The first one is the one early on, which is what we call RDS or respiratory distress syndrome, where, as you can see, depending on how severe your respiratory distress is, how severe your lack of surfactant is, the worse your X-ray will look like. This is a chest X-ray where you can see the right lung on the left and the left lung on the right, with your heart here in the middle. And the darker it is, the more air is in, which means the brighter it is, the less air, the more lung is collapsed. And the lower your gestational age is, the higher this the higher the degree of respiratory distress is. And as you can see below the X-rays, the gestation age gets lower and lower, the more babies will have moderate to severe RDS and actually would require surfactant to help you open up the lung again. The second thing, which also results because of a lack of surfactant, and over time, because we have to either provide non-invasive respiratory support or mechanical ventilation, is something what we call bronchopulmonary dysplasia, or often also called in when we do rounds and we talk to parents, we often also call it chronic lung disease. Now, this was initially described in 1967 as a new disease, which was really just something premature babies have developed and not any other kind of patient. And certainly we still call it this way, but from the original definitions, we have gotten a long way. Because if you go back 50 years now or 60 years, these babies were extremely old, 34 weeks. This is what we nowadays call late preterm infants. And if you are 35 weeks, in some hospitals around the world, even 34 weeks, you might not even get admitted to the neonatal intensive care unit. You might just stay in a postpartum ward with your mom or your parents. And 60 years ago, they all would have been intubated and ventilated. So certainly a much different time compared to today. And many of them, because they were ventilated and they were lacking surfactant, would have developed this bronchopulmonary dysplasia. Nowadays, we still use definitions of how to grade them, but they have certainly switched to much more fine-tuned definitions, as well as many of our babies do not get mechanical ventilated anymore. They just receive non-invasive respiratory support, but still might develop BPD because they did or did not get surfactant. And everything certainly starts just before conception. There's preconceptional effects, and today I really particularly will talk about surfactant as a delivery room and neonatal intensive care intervention. Now, what is the problem? Well, babies potentially are born with sticky lungs. What does this mean? Well, all of us who are listening will, and any other mammal as well, any human has surfactant in the lung. The idea of surfactant is to keep the lung open. It's a soapy substance which stays on the inside of your alveoli, which are responsible for gas exchange, and keep them open. This is extremely important. It's like when you have a balloon and you try to blow it in, and it's really challenging to open it up. If you use a mechanism to blow the air in, it might go much quicker or easier to blow up, and that is what surfactant is actually doing. So it is a thin layer which is around each of these alveoli. When you take it into your hand, it is a soapy like substance, and it keeps the air sacs, these alveoli, open. Without surfactant, they will collapse. And then you create something which is called atelectasis. And then you look at an X-ray, for example, then you could see that there is many more bright areas because those areas of the lung are collapsed. So it is an extreme important substance to keep the lung open. Now, surfactant was originally described around 1930 or so, where there was a hypothesis postulated that there is something in the lung to keep the lung open. And then over the next 20 to 30 years, the understanding of surfactant has then improved to figure out what exactly surfactant is, and also the potential of then finding out how could we harvest it, how could we create surfactant. Now, surfactant is produced in any of us in cells within the lung tissue. They are called pneumocytes type 2. You also have pneumocytes type 1. But in the pneumocytes type 2, these surfactant molecules are produced, and surfactant in general consists of lipids, some protein, as well as like cholesterol, for example. So a optimal combination to coat out the lung. Now, it's produced in your type 2 pneumocytes, and production roughly starts around 26 weeks gestation during pregnancy. So not much earlier. Nowadays, we also, take care of babies who are born as young as 22 weeks or sometimes even 21 weeks gestation. So at times where surfactant might not even be produced yet. But around 24 to 26 weeks gestation, surfactant is produced. Now, it takes around the next 10 weeks or so to up to 36 weeks gestation to increase the production of surfactant so that the whole lung has enough surfactant produced to layer it on every alveoli as a part of the preparation for being born at term gestation. So that means that if you're born premature, you might not have enough of that surfactant produced yet. In addition, and that's again for everyone, as the lung is opening and closing with every breath you take, Surfactant is used. So surfactant is not just produced once and stays there. It's you produce it, it layers the alveola, and then because of all the forces, it's being used. So you have to replace it on an ongoing basis. And again, it takes up to 36 weeks after, so 36 weeks of gestation, so that that production is in full swing. Now, when you're born premature, you potentially didn't have enough from the start, but you're also not producing enough until you hit the gestation of 36 weeks. Because as for many things, the body doesn't know yet that you were born, even though you're out of the womb already, because those mechanisms are still in the process of being developed and evolving. So these are one of the two things we struggle with, that premature babies don't have enough at the get-go, and they can't produce enough while they are being taken care of in the neonatal intensive care unit. Now, I already said that surfactant was initially described around the 1930s, and then over the next 20 to 30 years, there is more and more research into it to figure out how exactly all this works, what is responsible for it, and how could we actually create surfactant? Where can we get it from so that we can treat our patient? For premature babies who were born before 1950, there was no treatment available. It was challenging because it was actually unclear what could be done. Between 1950 and the 1970s, oxygen was our main treatment. Now, oxygen is an important drug which can fill 2 or 3 of these preemie chats. And we use oxygen a lot, but oxygen is also dangerous. So it's not something we use lightly. We only use as much as we need because we are worried that not enough oxygen is a problem, but too much oxygen is also a problem. After that time period, before the surfactant was actually available, and in the 80s or so, studies have started in the late 80s to examine the surfactant. We were really limited to oxygen as well as mechanical ventilation and CPAP, so continuous positive airway pressure, where you just apply some pressure to keep the airway open. Yeah, and if you don't know how CPAP works, is basically if you would close your lips and you try to breathe out through your mouth against the closed lip, this would create a continuous pressure, and this is then how you can keep your lungs open. So this is kind of how it works, but it also works when you inspire, so it works on both ends. And these were the treatments available. And then in the 90s, there were 2 amazing treatments available. One was anticoordinatal steroids, and the other one was surfactant. And then there's many other technologies which came into place to help us to care for our premature babies. But antenatal steroids was a major factor, and I will have a few slides, or a couple of slides on that. And then surfactant was the second big game changer in neonatal care. And these things I will now briefly talk about for the rest of my talk. Antenatal steroids, why are they important? Well, ideally, we want that moms get 2 doses of antenatal steroids prior delivery. If you're born less than 34 weeks gestation, that's the current evidence. Ideally, at least 48 hours prior delivery, so that those steroids have some time to work, and and so that they have some time to work. And why are they so important? Well, if you go back into the 70s and read the studies that done with antenatal steroids in sheep, um, you will see and understand that they were giving them to the ewes, where because they wanted to study things in those preterm lambs, and there's preterm lamb different to humans, but in sheep, um, giving antenatal steroids can introduce labor, which it doesn't do in humans, but it would do in sheep. And when those lambs, those preterm lambs, were then born, they were able to breathe and they wouldn't pass away. So antenatal steroids is actually helping to mature the lung, and it helps you by helping with the surfactant. So it helps you produce this more surfactant. So indirectly, those steroids help you to mature the lung, help you work on surfactant, helps the baby work on surfactant, and thereby improves your survival by up to 22%. So it's a good drug where we try to get every mom to have that prior delivery. It doesn't work in all moms because sometimes go unexpectedly in labor. It's rushed in and it happens. But ideally, this is something we like for all moms to have prior delivery. It doesn't help for chronic lung disease, but it reduces mortality, and this is one of the most important things. I think that it works that way. Now, let's go back to surfactant because, as I said, we have the collapsed alveoli, and that's because there's not enough surfactant. And once we give surfactant, those alveoli open up. And this is one of an older study, but that's still true today, that once you give the treatment, um, within an hour or two, this sometimes takes a little bit to get uh, the lung needs to adjust to having that surfactant. You can see that you suddenly need much less oxygen, and this is one of the indication when we give it, when the oxygen is continuously increasing despite, let's say, CPAP. You can see the oxygen increases, then we have to give surfactant because it's an indication that there is not enough surfactant in this preterm lung. If you don't do it, it will just continue to rise. But what we often see is that this effect, particularly in the extreme premature babies, this effect might last 2 or 3 days, and then because they don't produce enough and the surfactant is used, this effect can disappear. Ideally, within 6 to 12 hours, we repeat the treatment, but generally after a few days, if this occurs, studies have not shown that it is beneficial to do a late treatment. And also from a ventilation perspective, if the baby would be mechanical ventilated, which used to be our standard approach, you need much less respiratory support, and that stays on even after 3 days. So with surfactant, you can ventilate a lung much better compared to not using surfactant. Now, on the hunt to figure out what or where we can get surfactant, a lot of things have been examined, and I think the most commonly used surfactants are out of calves or cow lungs. The one which is commonly used in Canada is Bless. It's a Canadian company. It's a bovine surfactant, so from cow's lung. Another one which is used and is also used, I think, most commonly around the world is Curasurf, and this is one out of porcine lungs. So, and these two are quite commonly used within Canada. There are synthetic surfactants available. Some work better than others. Some are not used anymore, but there's new ones available. In particular, when I will talk later a bit about nebulizing. So there are newer synthetic surfactants available, which potentially are used nowadays more for nebulizing, but haven't been used for any other way. One thing I came across, but I've never used, is a surfactant made out of amniotic fluid. Now we have a baby who is born and would require surfactant. How do we do this? Well, we used to do it via, let's call it traditional delivery, where the baby would get intubated, gets a breathing tube, and after this breathing tube was inserted, the surfactant was given down into the windpipe. So what you need for that is one thing what we call the laryngoscope, where you place this laryngoscope into the mouth so that you can visualize your windpipe, and then you can place the endotracheal tube into the windpipe. This would be used for mechanical ventilation as well as for applying or administrating the surfactant. So that's the traditional approach. And this was used for many decades because we were always working under the impression that these babies need to be mechanical ventilated. Now, did it work? Well, it worked well, but a problem we had with using this approach was that we would give it everyone, absolutely everyone, and that wasn't potentially necessary. So any premature baby would get surfactant because we thought, yes, this is the right approach to do. But studies then have shown that, well, actually, you could just do it selectively if the baby meets a certain threshold. Before, a baby would have gotten intubated and would have gotten surfactant, regardless if the baby has needed it or not. And one of these studies who then showed, hey, you don't need to intubate necessarily because it's potentially better to keep it on CPAP as the first place and then selectively give the surfactant, actually showed that if you don't intubate particularly quickly after birth, you could reduce the number of babies who have BPD as well as mortality. Now you need 25 babies to reduce one BPD or death at 36 weeks gestation. And based on some of this research, we showed, no, you don't need to give it to everyone. You can selectively do it. New studies have been done, and they actually showed that just giving it selectively has an advantage. It's better for the babies, in particular, to reduce neonatal mortality. But this was just the start because people were, and they were still in the 90s, where people were still worried about, I don't want to intubate all these babies just to give surfactant. Now, is there other ways? Because once we started intubating, those breathing tubes were kept in for days, sometimes for weeks, because that's the approach we did. And based on that we wanted to keep these babies on CPAP, where there's just a bronchi on the nose to provide this positive pressure. One of the ideas was Ensure, where once again you put this laryngoscope down, put the breathing tube in, and then you quickly give the surfactant and extubate. So Ensure, intubate, surfactant, extubate, to put the baby back on non-invasive support like CPAP, so that you avoid prolonged mechanical ventilation, because we know that mechanical ventilation increases your bronchopulmonary dysplasia rates. So we don't want that. So this was one approach, and this was from the 1990s, where this was done, where you give early surfactant with this Ensure approach, and then put them back on CPAP versus giving selective surfactant, and you continue to ventilate. Now, unfortunately, looking at these studies, it didn't show, if you just look here at the bottom of this plot, this black diamond is the most important one. If it crosses 0, it does just mean it's not different between those two interventions. You could argue there was, because most of the diamond is to the left, so there maybe is a trend to use Ensure, but overall it didn't show there was a difference. So while Ensure gained tractions because many sites wanted to avoid mechanical ventilation for a longer period of time, it wasn't superior to just selectively pick the babies who need surfactant. And there are certainly many flaws. We can discuss why this might was. In particular, many of these studies are like 30 years old or so, and a lot of care certainly has changed since then. But based on these studies, Ensure was used, but it didn't gain as much traction as the inventors of Ensure might have thought it will gain. But based on this idea that, okay, I don't want to keep the baby intubated, I just want to give the surfactant, approaches like LISA or MIST have been developed. With these approaches, again, you potentially you put your laryngoscope into the mouth. You have a catheter, which is not an endotracheal tube, but I couldn't find a photo like this, which goes into the trachea while the baby is supported on non-invasive respiratory support. And this is called LISA or MIST, and they stand for less invasive surfactant administration, which is a term used in Germany, and so all German-speaking countries. And MIST is the approach used in the English-speaking or the rest of the world, which just means minimal invasive surfactant tracheal administration. The only reason why mist is not a good word in German is because it means manure. And if you want to talk to parents about the study, that might not be a good word to be used. But it's a thin, flexible catheter which gets inserted into the trachea. Again, as I said, you go in with the laryngoscope, but the baby is continuously breathing spontaneously. With the two previous techniques, like the traditional delivery or Ensure, most will get some kind of pain medication, often morphine or fentanyl, some sedation potentially. Traditional intubation will also have a muscle relaxant, so that will also prevent you from breathing. Now, if you are on non-invasive respiratory support, breathing prevention would actually be counterproductive because you want that baby is continuously breathing while you're doing this. And there's 3 different techniques which all do the same, but they just use different tools. One is the clone method, where they use just a feeding catheter, where they use a forceps to place it into the baby's windpipe, as well as they take care. And Hobart methods, where they just use like angio catheters or other stiff catheters, which are placed again with the laryngoscope into the windpipe just below the vocal cords to give the surfactant. Now, does it work? Yes, and this is now become kind of the standard of care for many units, for many babies around the world. The first studies you can see here, there were small studies, but they showed quite promisingly that if you do it, and they were early on really just looking, if I do it that way, can I prevent that the baby gets mechanically ventilated? And the answer was yes. And you see that if I only do 6 babies where I use this LISA approach, or the MIST approach, then I can prevent one baby from being intubated and ventilated. Now, this was in 2011, so more studies were needed. One of the largest studies, the Optimist trial, um, also showed yes, it is possible, uh, and you will actually able to reduce the number of babies who have bronchial pulmonary dysplasia who survive to 36 weeks. So it is an effective approach because you can prevent um, intubation and mechanical ventilation. What's the caveat of many of these studies? That many of these studies always have a control group which didn't get surfactant. So you could argue that, well, they actually didn't compare two treatments. They compared the treatment early versus the treatment later, because all got treatment, but often a bit later because they wanted to see a difference here. So it might have not been the optimal studies to identify if these new techniques are perfect. But again, you cannot just do a study where you say one group gets affected, the other one wouldn't get affected, because that would be, again, unethical. And I would not know any clinicians around the world who would say, yes, this is a study I want to do. So that's certainly something where um, all the studies have some limitations. Overall, all the studies who have been done on using this thin catheter, and you can see there's quite a lot over the last 15 years or so, or 10 years, have shown similar results. And again, if you look at any of these graphs, which are called forest plots, because all these dots look like a forest, you can see overall that it reduces the rate of respiratory distress, rate of mortality by up to 40%. So it's a really good treatment to use this approach. And this is now used across the world by many units around the world. It's not used in all babies. It's often used in potentially 25 or 26 weeks premature babies and older. Some units use it in 23 and 24 weeks. Other units potentially use these smaller premature babies. They still intubate and give surfactant that way because of their experience that these babies need mechanical ventilation, maybe in a few hours anyway when they get tired of breathing on their own. So another one who compared that now to Ensure, which was the technique where we intubate and then give surfactant and extubate, also showed that, hey, if you do LISA or MIST, you can reduce BPD by around 35%. So again, great approach because you prevent mechanical ventilation, because with Ensure, you still put that breathing tube down, you still will do some mechanical ventilation. And I think more recently also, we found out that, well, we used a lot of different thresholds. And when I started neonatology, it was often 60%. Some units where we're doing 40%. Nowadays, we do 30%, and often even the lower you go in gestation, even lower thresholds, because we know that the earlier you potentially do this, the more likely the baby has a better outcome. In particular, mortality, because this is one of our most important outcomes. So the threshold certainly over the years have moved down to lower and lower percentage of oxygen, which also means more and more babies will get surfactant because they reach that threshold sooner than previously. Good. Now, the next step is aerosolized surfactant. There were a couple of slides who were repeated. I apologize for that because they were talking about mist again. Now, a potential future solution, one of them, is aerosolized surfactant. Now, aerosolized surfactant is again where you stay on your non-invasive respiratory support like CPAP, and you get a surfactant which is aerosolized. Now, problem with that is that the surfactant we have potentially doesn't work because the particles do not get small enough to go down the windpipe, because what you don't want is that all these particles stay somewhere in your pharynx, because that's where they just get pushed against the mucosa and then they stick there. So that's certainly something which you don't want. So there have been done a lot of studies to figure out what is the optimal molecule size to get it into the alveoli, because that's where you want it. And it's certainly still an area of great research. Does it work? Well, yes, it works. Like, you can reduce the severity of respiratory distress. You can reduce the number of babies who get intubated, but potentially it works better in older kids than younger kids. So 32 weeks and above, and not in less than 32 weeks. But again, this is a future technology where over the next years there will be many more clinical studies occurring. I think one is just happening in on the east side in Canada as well, because we're not there yet. We have done, there's a few studies who have been conducted, but they are not conclusive yet that it works well. So there's more work needs to be done before we can use this as a routine approach. Another alternative, maybe not for the extreme premature babies yet, but could be also on the horizon, is the use of a supraglottic airway device. Now, what is a supraglottic airway device? Well, a supraglottic airway device is a device where you place a device into the mouth, into the pharynx, which has an area which then basically covers your glottis and your larynx. And then there is an opening where you can get the air into your windpipe, and it closes off the esophagus. So that's a alternative tool to intubation, which was developed in the 1980s by a British anaesthetist, and he called it laryngeal mask airway. Often nowadays they also refer to as supraglottic airway devices, or SAD or SGAs, because there's many different shapes and forms available. But this is an upcoming research, and this is how it looks like. This is what you can put in from a size perspective in our premature babies, and a few studies have been done. And again, what they compared was like just leaving them on CPAP or comparing it with Ensure. And in both of these analyses and comparison, supraglottic airway surfactant was faster. Now, in the US, it's often referred to as SALSA. The Callum Roberts is a colleague out of Australia, of Monash University in Melbourne, and he, together with Joyce O'Shea from Glasgow in the UK, running a trial which our site, for example, as well as Saint Justine in Montreal, is participating, which is called SurfSup. And so in babies who are greater than 1,250 grams, we actually randomized them to give that with supraglottic airway device versus LISA or MIST to see if it actually is better. So, and nowadays we also have laryngeal masks or supraglottic airway devices, which go as low as 600 gram. So maybe this is something where we could also try this now in smaller kids and see if this is a approach which works. They are well tolerated. These babies are all awake. They can look around. You place the laryngeal mask, you connect it to CPAP, and then you give the surfactant, and this is all well received by the babies. There's no struggling or anything, so that may be a next step in how we do things. Other things people have tried is, for example, just to put it into the mouth and hoping at birth, when the baby is taking a deep breath in, that with all the lung fluid which is in the lung at birth, that it goes into the uh, into the into the lung, into the alveolar where it should be. Unfortunately, a large trial trying to see if that works didn't show any improvement, and it also showed that babies who got that had significantly more pneumothoraces. So a rupture of an alveoli somewhere with free air in the chest. So maybe the idea was great, but it wasn't maybe not perfectly how it was delivered. So maybe there's a different way in the future where we could potentially give it in this way. Another approach to try this to mix surfactant with a steroid. So I already mentioned antenatal steroids. And so budesonide, some of you might know, many people who have asthma would have an inhaler, which potentially has budesonide in, which is a steroid to reduce inflammation. So they try to see if it works to potentially help giving it together to prevent bronchopulmonary dysplasia. There's a couple of small studies out of Taiwan which showed a tremendous success that if you do this, you could basically almost half your rate of bronchopulmonary dysplasia. And that sounded like almost too good to be true. In all the studies out of Taiwan, it worked really, really well. Unfortunately, two studies, one from the US and one out of Australia from Brett Manley from the Royal Women's Hospital in Melbourne, showed yes, it works, but it doesn't reduce anything. So the primary outcome of having less bronchopulmonary dysplasia at 36 weeks was not different. So in small studies in Taiwan, it worked. Unfortunately, in larger studies, either the US or from around the world, it didn't show any improvement, which was unfortunate and quite disheartening because there was so much promise in this approach. Now, I'm at the end and I'm looking forward to chatting with everyone. I'm thanking for your attention. And while we potentially are at the next step of using maybe laryngeal masks as our primary approach of giving surfactant, there's many areas where we still need to find out what's the right dose, how often should we give it, do we need to continue to give it, different approaches like with nebulizing something we should potentially do, or maybe once the laryngeal mask is established, is nebulizing the next step to improve outcomes for our premature babies. And with that, I say thank you and looking forward to the chat.
Thank you so much for that presentation. There's so much in there. Thank you. That was really fascinating to kind of understand how something has progressed over time and what hope that gives for what might be to come in the next 5-10 years of research in this.
Oh yeah, it's a fascinating area. Yeah. To see where we go and where we have come from.
Mm-hmm. I'm wondering one thing that I'm not sure if I missed it or if you didn't talk about it. When you're determining when to use this intervention, is it just based on the gestation of the infant, or is it based more on their size physically?
I think every unit has their own kind of policies. Like a lot of units, I think, would, let's say, 30% oxygen in older kids, like let's say 26 weeks, 27 weeks potentially. They say, okay, at 30%, I would give it. If they are like 22, 23 weeks, potentially, when you intubate, you automatically give surfactant because often they need more oxygen anyway. Other units do it by gestational age. So it's at the 27 weeker, they need to have 27% oxygen or more to qualify. So I think it depends. And others potentially try to optimize the CPAP or switch to what we call non-invasive. We call NIPPV, so which is CPAP gives you one pressure, NIPPV biphasic. There's so many different terms out there depending on what ventilator you use. It gives you two pressures, so they might optimize this before they start giving the surfactant. So that it's not really easy to get one approach. It's really most hospitals will have certain rules.
Okay. And that might also be kind of the answer to a question we had from Sandy, who is watching, wondering about, when is the best time to use that? So, how soon after, the infant is born are you using this kind of intervention?
Again, that depends on how much oxygen the baby needs. We generally give it in the first 2 days, in most cases. After 3, 4, 5 days, studies have shown it doesn't work well. It doesn't improve outcomes. So ideally, in the first 48 hours after birth. And again, it will depend on the oxygen. If the baby is soon after birth in high oxygen, you will give it sooner. I can't speak for all of my colleagues because a lot of people have different opinions. But if you don't get angionatal steroids, some might give it faster because they know, the steroids are missing, so they're more likely that they need it. Other kids who had more stress in utero might have better lungs. If you're born AOGR, often so small for gestational age because you didn't grow as well in utero, they often have better lungs because they're more stressed, so they have more of this surfactant produced. That might get it later or less likely, because it always depends on how the baby is. So many get it early, within the first 30 to 60 minutes because they need it. But some babies, particularly when they're, let's say, over 30 weeks, they might need a day or two to show they need it.
You kind of touched on it a little bit there about, whether or not stress may be a factor in whether or not you're producing your own. Can you talk a little bit more about, what we know about how and when we produce surfactant?
Yeah, I mean, you start at 24 to 26 week to produce surfactant, and you produce it 24/7 until you die. Because if you don't produce it, your lung is collapsing. So everyone produces it, but the premature babies, because they're born at that time, that just don't have enough and don't produce enough in a rate, they using it. So they're wasting it because you waste it when you breathe, and they don't produce enough quickly enough. So that's the main problems they have.
Just before we wrap up our time here together, I'm wondering if we can kind of end on that hopeful note and talk a little bit about what you are hoping to see in terms, particularly of non-invasive measures and advances that might happen in the coming years.
Yeah, look, I mean, we're participating in that study with the laryngeal mass. So I think that might be the next step, because yes, we always talk about minimal invasive or others call it less invasive but you still put this laryngoscope down the throat, and I don't know if just not having a breathing tube instead of just having a a feeding tube in, it's less invasive. In my opinion, this is a big pain. You get a big pain response. So anything, I mean, could be the laryngeal mask, could be nebulizing, could be something completely different. Like approaches we haven't thought of, which would be the next step. So certainly excited to see those absolute less invasive or maybe non-invasive approaches, which potentially we haven't thought of, to come and maybe be the next thing in the 5 years or 10 years.
And one final question for you: when it's being given through those various procedures, are any of those times when parents can be kind of actively involved in, holding their baby or being part of the process?
Yes, we always try to integrate the family as much as possible. I think most units don't have parents holding the baby at that time. In particular, just because often when you do this, there are like 5 or 6 people involved in getting that breathing tube in. But why not? Have parents present as often as possible. As with everything, some parents want to be there, other parents, struggle potentially to see that procedure anyway. So they wouldn't be part of it because they can't, and that's fine. I think on the other hand, early on, sometimes, particularly when, let's say, there was a C-section or so, moms might be still on the operating table. It would be challenging to be there, because we tried to be away from the operating room at that time. Dads can be involved, the other partners could be involved, for sure. So I think there's always ways of getting them involved, and I think it's sometimes the willingness of the medical clinical team that prevents that, or is a barrier that can happen.
Maybe another way that we'll be able to find improvements over the coming years. So,
for sure.
Yeah. I thank you so much for taking the time to share this with us today. It was really fascinating to hear the history and the evolution and to see where we might be headed next.
Thanks for having me.
And I want to just remind everyone, my guest today was Dr. Georg Schmölzer. He's the director of the Center for the Studies of Asphyxia and Resuscitation at the University of Alberta, where he's also a professor, clinical scientist, and practicing neonatologist. You'll be able to see a replay of our presentation and our discussion on our website. That's canadianpreemies.org. You can see it there on the screen. You can find all kinds of other resources on our site as well, including we have an RSV fact sheet that's available in 19 languages, and we have all kinds of resources around World Prematurity Day, which is coming up November 17th. And I'll take this moment to remind you that next Friday for Preemie Chats, we will be talking about World Prematurity Day. We'll have a special long version of the show. I hope that you'll be able to tune in. I'd like to thank you all for watching, for taking part. Thank our sponsors for making this possible. And I hope that you all have a wonderful weekend.